the chair. For those of you that are speaking, please make use of the microphones, otherwise the people online will not be able to hear you. You'll know it's on when the light around the top goes red. It should just require one tap. Please turn it off when you finish using it, because I think in this room only 2 can be on at any given time, so you end up cutting people off if you sort of are a bit too quick on the microphone. So please bear with us on that. My colleague is about to bring some blank paper around. I'm sorry, we're remiss at printing off nameplates. So as the meeting progresses, it would be really kind of you to write your names down on the nameplate, so everyone's very clear on who's in the room. I think the chair will also at some point ask you to briefly introduce yourself as well. So with that in mind, I'm going to hand over to my colleague Isaac, who will be clerking today's meeting. So thank you very much for your patience. If you have any sort of, oh, I should say, if, in case of a fire alarm, please follow the fire exits. We also have a colleague from security here that will help guide out, sitting at the side as well. So I will be quiet now, hopefully for the rest of the meeting, leave you to it. But thank you very much. Isaac, I'll hand to you.
Thank you, Polly. Good evening. I'm Isaac. I'll be clerking the meeting today. This is the meeting of the Inner North East London Joint Health Overview and Scrutiny Committee. As you are aware, the meeting is being recorded. The recording will be made available on the City Corporation's YouTube channel following the meeting, and it shall be retained for up to 1 civic year. The first item on the agenda is the election of the chairman, Common Councillor David Sales, being the only member indicating their willingness to serve and being the only member from the City of London Corporation who's hosting the meeting, will duly be elected the chairman. I'll pass over to the chairman.
Thank you, Isaac. And can I sort of first of all just give you a very warm welcome to Guildhall, and thank you for allowing the City of London to host these for the next couple of years, and thank you all for those that are in the room for coming to the city, and welcome those online as well. The next item on the agenda is for the election of the vice chair. A note was put out to everyone, and the only person that expressed an interest for vice chair is Councillor Masters. So I would like to formally invite Councillor Masters to become the vice chair. Everybody happy with that? Yeah, thank you. Thank you. So can we check if are we quorate? Do we know?
Yes, Chair, I can confirm we're quorate.
Okay, thank you. Makes it a little bit easier when we come to the minutes of the last meeting. So do we have any apologies for absence and any substitute members?
Thank you, Chair. We have 2 apologies for absence. We have Councillor Anna Lynch and Councillor Daniel Morgan-Thomas.
Okay, thank you. Now, as this is a newish kind of group, I hope you don't mind if I ask you just to quickly introduce yourselves and the authorities that you're the representatives of, just so that everybody knows who they are. I mean, I'll start off. David Sales from the City of London. I chair the Health and Social Care Scrutiny Committee for the City of London.
Councillor Susan Masters. I chair the Health and Adult Social Care Commission in Newham, and I'm now pleased to be announced as Vice Chair of the JOSC.
Councillor Danny Keeling, London Borough of Newham.
Richard Sweden, Councillor for the London Borough of Waltham Forest.
Councillor Jennifer Wilby, Waltham Forest.
Councillor Ben Hayhurst, Chair of Health in Hackney.
Councillor Ben Lucas, Vice Chair of Health in Hackney.
And online, I can see we've got Councillor Sam O'Connell. So hello, Councillor O'Connell. And
thank you, Chair.
Is there any other? Oh, sorry, we have somebody else as well.
Councillor... Hi, Chair. Hi, Chair. Good evening, all. My name is Councillor Ahmed Al Kabir, and I am the General Purpose Committee Chair in Tower Hamlets.
Okay. Thank you.
Hi, David. It's Alderman Liz King here from City of London. Congratulations on your election. Congratulations to your deputy. This is my first meeting and I'm very pleased to be here.
Well, thank you very much for joining us. I did invite some of the members of the City of London Health and Social Care Scrutiny Committee to come along as observers today. So I hope that's everybody's happy with that. Clark, what comes next?
Did we do declaration?
We haven't done that.
No, I will.
Right. Has anybody got any declarations under the code of conduct that they wish to raise, or any items on the agenda?
Thank you. I'm a member of the Socialist Health Association, an offshoot of whom are mentioned in an item later on in the agenda.
So moving on to the minutes. Oh, sorry, Councillor.
I'm similarly a member, Chair.
And I'm also a member, Chair.
Okay, thank you. So moving on to the minutes of the previous meeting, they have been circulated. Has anybody got any comments on the minutes from the previous meeting? Is that all agreed? Thank you. So now we move on to item 6, which is the public participation. As I understand it, we have 2 representatives from the public that wish to speak. I have Stephanie Davis Arl and Councillor Lynn Troughton of Hackney. So as the clerk mentioned earlier, please can I ask the first one of those if you can come up and sit here and then use the microphone so that everybody can hear you. Yeah, that's fine. Yeah. 3 minutes, please. Yes. Yeah.
I'm timing it and I'll let you know. I'll let you know when you have 30 seconds left.
Okay, you push the button there to
Okay.
speak. Okay.
Hello everyone, I'm Stephanie Davis-Sarai and I've just come to speak about the CAS review and how that has implications for schools and children's services. And I'm just going to go through the most important things from the CAS review. It is the most extensive, comprehensive review of children's gender services in the world, and it has had global influence. It used gold standard research, so systematic reviews of the treatments, both medical and social. So that's looking at all the studies ever done on puberty blockers, cross-sex hormones, and also social transition, which is really what I want to, which is the most relevant in terms of schools. CAS found that social transition, there is inadequate evidence of benefit, but increased risk of progressing to medical treatment. So I think for that reason alone, social transition should not be done in schools because that's a huge risk that children are set on a medical pathway, which they're more likely to go on to. And once they go on to puberty blockers, they are, the Tavistock Clinic's own study showed 98% then progressed to cross-sex hormones, which are irreversible treatments. So when children grow up, if they regret their treatment, they can't reverse it. They're stuck. So that these are very serious medical interventions that children go through. So from what happened with the puberty blockers, because the evidence was inadequate, was the Tavistock, the new gender hubs, puberty blockers were banned and they'll only be given within a clinical trial. We can't do a trial of social transition in schools. The difference between CAS and the responsibilities of a school, a clinician has only the responsibility for the patient in front of them. A school has responsibility for every child in the school. And a social transition of one child affects every other child in the school if they are compelled to pretend that a boy is a girl or a girl is a boy. 30 seconds. And it is also, it doesn't work to do a sort of case-by-case basis, that if the clinician says or advises on social transition that we should do it, because a clinician doesn't have the authority to prescribe the behaviour of other children in the school by prescribing the language they should use or how they should treat that child. The clinician only has responsibility for the patient in front of them. So there are reasons that I think the CASP advice and recommendations are on the MindEd hub for all professionals working with children.
Probably aware, we do have that item on our agenda for the members to discuss later. Well, of course, you're welcome to stay and to hear that. So thank you. Thank you for your representation.
Should I stay to join in with?
No, unfortunately, you're not. The participation is limited to the elected members.
Okay.
So this part, the public participation, is really just to give you the opportunity, just to make ask a question or make a representation.
Okay, so I wouldn't be able to come in to people ask me questions.
I'm sorry, no, that's
No,
not. That's not.
I just want to know, because I don't know whether to stay here and listen to further council business. Or
if you wouldn't mind, because we've got somebody else that would also like to make a representation. And if you wouldn't mind sitting over there back side bit, but thank you. Can I now invite Councillor Lynn Troughton to?
Thank you. Yes, I'm Lynn Troughton. I'm here not in my official capacity. I'm here as a concerned resident. So I need to just state that clearly, although I have advised residents on the process for bringing concerns, to public scrutiny. I'll just build on what Stephanie has just said. The Secretary of State for Health has pledged to implement the CAS recommendations. These were wide-ranging, with having particular implications for the well-being of lesbian and gay children who were in effect subjected to conversion therapy within the Gender Identity Development Service as it was operating at the Tavistock. The DFE has also responded by issuing new guidance, and yet it appears our health authorities are completely ignoring the CAS review, despite the severe and serious implications that, the practice of gender affirmation is having on our young people. The very least I would expect from the health authority, it is a safeguarding issue, is that they should, put an immediate stop to the practice of gender affirmation by GPs, general practitioners, who are making the referrals and hence increasing the waiting list for the gender services. There should be a working party established within the health authority to develop a strategy for those children who are on the current waiting list, and a statement of intent that acknowledges government policy on this issue. Also, in the light of the Supreme Court judgment, which has ruled on the definition of sex, this really firms up the CAS recommendations, and there should be no reason for any responsible institution to be stalling on the implementation, of these very clear and wide-ranging, recommendations. I'm concerned also about the operation of private clinics that are going under the radar. I would expect the health authority to take a position on those and to be doing something about those. I think that's more or less all I wanted to say at this point, but I would just urge the Scrutiny Commission to, take the issue very seriously and, hold their authority to account. Thank you for your time. I appreciate it.
Thank you for your representation. we will now move on to because I know there's a lot of interest in this particular item. We're rescheduling some of the items on here to bring item 9 forward, which is the LGBTQ plus health services, and we have the Chief Medical Officer here to make a presentation on that.
Thank you, Chair. Just to reintroduce myself, my name is Dr. Paul Galuli. I am actually previously the Chief Medical Officer. I am now the Chief Clinical and Quality Commissioning Officer because we've restructured at the ICB. But my background is medical. The other thing I have to confess to start off with is my clinical background is I'm a consultant forensic psychiatrist. So I worked in mental health for 31 years before moving to the ICB in 2022. I've not going to go through the slides in a huge amount of detail, but I'll give you a thumbnail of the slides and what I've tried to lay out in the slides. The first bit is the gender services and what the gender services provide and who they provide services for and what symptoms that people have. Previously, as has been mentioned, we did have one national clinic for gender issues in children, which was based at the Tavistock Hospital. There were concerns expressed at the Tavistock regarding the Tavistock Hospital regarding quality and clinical pathways at the Tavistock. This resulted in the NHS England commissioning Professor Hilary Cass to carry out a review of the children's services at the Tavistock. This report reported back in April 2024 with 32 recommendations, and the Tavistock Clinic subsequently closed in April. The new recommendations from the CAS report is a nationally commissioned service. We do not, as an ICB, commission gender services. The gender services for children and for adults are commissioned nationally. That's the first thing that's really important to say. The CAS report has recommended that there's 2 clinics to start off with, one in Manchester, one in London, but ultimately to have 8 clinics throughout the country on a regional basis. Those clinics are very different from the model that was had at the Tavistock Clinic. It involves paediatricians, it involves psychologists, it involves psychiatrists. So the one within London is a joint clinic between Great Ormond Street Hospital, the Evelina Hospital in South London for children, and SLAM, which is the South London and Maudsley Mental Health Trust. At the last time that I asked regarding the waiting list for a children's gender clinic, at March this year, there were 6,000 children on the waiting list. That waiting list is nationally managed and nationally triaged and reviewed on a regular basis. Presently at Gosh, the South Hub, there is 194 patients actually going through process at the minute for assessment, and of these 3 are from North East London. The speakers mentioned before, the restrictions have now been put on puberty blockers. Initially, the Secretary of State made that just a temporary review, but that's now made a permanent review, and she's absolutely right. They're only allowed to prescribe puberty blockers in children with gender dysphoria if it's under a research proposal. There is also a review presently being commissioned for the adult services. The last slide is to look at inclusive care that we really try to think about for all our residents, no matter what background they have and where they come from. I talk a wee bit about the LGBT community and how it's marginalised in general, and how we've used Pride in Practice, which is a nationally awarded input to GP practices to look at how we can make GP practices more inclusive of the LGBT community. I'm happy to take questions.
Thank you, Paul. Can I open it up to comments or questions? Does anybody wish to make any comments? Councillor Keating.
I understand the questions I'm going to ask you because we're speaking as in the northeast London. You might not have the answers to because of course, these are national items. But since the ban of puberty blockers, have any people on the waiting list taken their own life?
There has been a report recently of a coroner's case, but I don't have the figures or anything of how many suicides or anybody taking their own life on the waiting list. As far as I know, nobody, but I would have to check that with the National Service.
And since this decision, how many in our area have required extra mental health care?
Again, I would have to check the figures for that. Most children will be referred initially to the CAM service, and the CAM service will follow them up. And then a referral will be made from the CAM service to the gender clinic. Within CAM services, and I know this from our clinical experience, within CAM services, everything is personalised depending on the child and depending on the family, and that will vary depending on what their needs are at that time, and will fluctuate during that time as well. So I don't have the figures for, you know, that particular group at that time.
Is it the case that we wouldn't have those figures though, because they would already be undergoing some kind of mental health help, I suppose, or
I think what you're saying is
in the first place?
So I think once a child is referred to the CAM service, they're receiving support. Now, if that support is sufficient enough for them to be that's absolutely fine, and they can go on maybe the waiting list until that occurs. It might. The other thing that there is quite commonly as well is comorbid diagnoses. So there might not just be gender issues, there might also be neurodiversity issues, there might also be mental health issues. So it really depends on the individual child. I think to give a group when there's such variation within that group is really, really difficult to give.
And the closing on the Tavistock and Portman, has this had any effects on the waiting list for care?
I think the first thing to say was that I don't remember the date off the top of my head. The waiting list was first closed before the Tavistock actually closed. So ultimately, if you close a service, if you close the waiting list before you close the service, the waiting list will increase during that time. They've taken time to build the services up because it was difficult to get recruitment and everything else into those services. But it's difficult to compare and contrast because referral levels will change depending on a variety of different factors. But I can give you the fact that that's how much was in March this year. I don't know right today how much is sitting on the waiting list today.
And my last question is, since the CAS review, and with the current politics that are going around, as we heard from members of the public a minute ago, and the likes of very far-right activists, has this had any knock-on effect to NHS staff with opinions for being inclusive and for those in the trans community?
I think I would reiterate again what I said in the presentation itself. I think from an NHS perspective, and particularly from a North East London ICB perspective, we respect all our local residents and they should receive compassionate and kind care in the right place, at the right time, for the right person. And that doesn't matter where they come from. It's the NHS constitution.
Thank you very much.
Councillor Masters.
Thank you. 3 patients in the North East London ICB area seems terribly, terribly low. What do we know about unmet need locally? Is anyone doing any work to ascertain levels of that?
I think we could look at that within the CAM services, and the CAM services certainly pick up that. I don't think it's unmet needs as such because they're receiving support whilst they're on the waiting list anyway. So there should still be support for those children. It's not as if they're just put in the waiting list and then left. So I think it's difficult to say it's unmet need because they should be receiving it from CAMS.
But it just feels like to me, if they're receiving support for those kind of issues, that they should be included within those numbers, even if they're not technically patients, just so that they're sort of properly represented.
That's a fair comment. I don't have the figures off the top of my head, but I can get the figures to look
That
at how many
would be
are on the waiting
fantastic.
list.
I think we'd all like to hear that.
Councillor Hayhurst.
Thanks, Paul. Just to try and understand, so the 2 hubs, the London and Manchester, are they up and running now?
Yes.
Or they are, but the full 8 isn't? Is that right?
Okay, that's correct.
And then I'm just trying to get my head around the wait list, because the obviously the figure being 6,100 on a wait list, but the want transferred to a service, the assessment being just under 7 weeks, which in the grand scheme of things is okay, maybe a bit longer than we'd like, but not too bad. So what's going on there? Why is the difference? Because obviously if the wait list is only sub 7 weeks, why there's 6,100 on the wait list? Can you just explain? I'm not 100% clear what's going on.
I think it's so what they've done nationally, it's a national decision to do, is they've got a large waiting list which they are managing the waiting list. They then triage the waiting list to look for those who need the most care and urgent care, and they then transfer them from the waiting list onto the waiting for the actual hospital. So there's 2 waiting lists that are kept separately.
Councillor Sweeten.
Thank you very much, Chair, and thank you, Paul, for your report. We just heard assertions made by the 2 members of the public that somehow the ICB or we should be directing schools and GPs or other clinicians as to how they should act with regard to people, particularly young people, assuming a particular gender identity. Would I be correct in assuming that neither of us are empowered to do such a thing? And if you'd forgive me for not having read every paragraph of the CAS review, I don't believe that the CAS review calls for such action either.
So I would firstly say that I think you're right. I think we're not in the position to turn around and tell GPs that they need to act in this way. It certainly was not in the CARS review, and it's not in our remit to do it. GPs have a medical responsibility to treat their patient with respect and make sure the patients are receiving the full care and not receiving harm. So that's my bottom line, and that you can interpret it how you want to interpret it, but that's what my view is. Now, from an education point of view, I think that's a council view rather than an NHS view. So I don't have any responsibility over the education system. And again, if the government wanted to do anything, the government could decide that from an education perspective. It's not for the ICB to decide how education units should work.
If there's no other questions, sorry, yes, sorry, at the end.
Thanks, Chair. I just wanted to ask a quick question around inclusive care and treatment more broadly. You mentioned obviously the Pride in Practice programme and some of the other measures being in place. What sort of review mechanisms are in place and to show that they're working consistently? What's the sort of feedback you're getting around that? How is it working in practice? What are the specific things around that programme that you mentioned to ensure it is truly inclusive?
So we've got a variety of different Pride in Practice that's come in. Tower Hamlets in particular have decided that all their practices will go through the Pride in Practice system. And I think they've got about 75% of their practices have now gone through the process. The feedback, and I went to the awards when they were actually the gold, silver and bronze awards. I went to the awards for the first practice that was actually went through the process. They were very, very impressed and felt they had learned a huge amount. And it was not just for the doctors or the clinicians, but actually for the receptionists, for everyone to actually understand things which they then could, once they were hearing it from another side, they could understand what it's like to be in somebody else's shoes. So they're much more inclusive and much more thinking about what they were doing, but felt that whilst they'd gained the law, there was still quite a gap that they would like to go through it again at some bit in the future. This is not just a let's do it once and that's it. This is maybe let's do it once and then maybe in 2 or 3 years' time, 4 years, 5 years' time, do it again and just check, are we still, up to speed and where we should be? Because within North East London, we have a large LGBTQ community, and it's whether we're meeting those needs.
And you mentioned that 75% figure. What work's being done across sort of region to make sure that goes up and that more are getting involved in it?
So within the training hub, there is also funding within the training hub for practices out with Tower Hamlets. I would be lying if I was to tell the figure off the top of my head. But there's 3 or 4 in each area that have gone through the Pride in Practice process as well. So we're trying to get a spread right across North East London so that that's a consistent approach within practices. But also, obviously, it depends on the practice deciding that they want to pick it up.
Thank you, Councillor Lewis. Lucas. Councillor Keeling.
Sorry, I just have one more. I imagine you don't have these figures on you, and I would like to request if we could get the figures of the amount of trans adults and trans kids going through care and treatment in North East London on the waiting list.
Okay.
For care.
The waiting list for children, it definitely is no problem. The waiting list for adults who are waiting for their first appointment for the gender clinic, I can get as well. That's easy enough to get that build up. When you say care and treatment, though, I'm a bit unclear.
So gender affirming care. So we're going through transition. Just put it in context. I represent the ward which has the highest trans population in the whole country.
Right.
And I have a large amount of residents saying they've been waiting years.
The waiting list for the adult service is huge. And I'm meeting with Spectra, the trans advocacy, to discuss with them about, because the waiting list takes so long, a lot of residents are going to private for private assessments and then coming back to the GP and asking for prescribing hormones, and the GP feels very uncomfortable because they don't know how good quality the actual private assessment is. So I think there's some work we have to do around about that, and I'm trying to do it at a London level rather than do it just at a North East London level, so that we get some consistency right across London, because we want to make sure all our residents are receiving good quality assessments and good quality care.
Absolutely, thank you.
I'm sorry, we're not able to take any comments from the public. Apologies. If there's no other comments on this item, then thank you, Paul, for presenting, and we'll move on to the next item. So thank you very much.
I can stay a wee bit longer because I think Dr. Masters, Councillor Masters, even you've got some questions about health inequalities.
I think it was more about the comments on talking therapies that we heard at the last meeting and the response to them. I mean, there might have been some general comments around the ICB papers. I think there was a comment in there about health inequalities. So, yeah.
Want me to stay up a bit longer?
Yeah.
I can stay to 8 o'clock.
Okay. Thank you.
Okay, so moving on to we're going back to the agenda for the health update. Welcome, Zena.
Good evening, everybody. Thank you, Chair. So I won't obviously go through the entire slide pack on the health update, but I will pick out a couple of points of specific note. I just wanted to start by saying this is my last inner London JOSC. I still have one outer London JOSC to go. I think we're trying to arrange a briefing separately, just an informal briefing on integrated neighbourhood teams. So I'll hopefully see councillors again before I go. But we have just appointed Ralph Coolbeck, who's just popped up on screen, as our interim chief executive after I leave, whilst we recruit a substantive chief executive. So I just wondered whether Ralph might just briefly introduce himself to the committee.
Thanks, Zena. Good evening. My name's Ralph. I'm currently the Chief Strategy Officer for North East London, and as Zena said, I'll be stepping into the interim Chief Executive position next month. I've worked in North East London for a while and previously worked at Barts Health and at Whipps Cross.
Lovely, thank you.
Welcome, Ralph.
Thank you very much, Ralph. So I just thought it would be helpful for the committee to sort of see that and be part of that transition. On the subject of organisational change, we've included in the pack a brief update on what's happening with the organisational change in the ICB. You will have probably seen that that slide or variant of it before, because although when the announcements about changes to ICBs were made in March, I think, and we were expecting it all to happen quite quickly, there isn't yet a national decision on the funding of redundancy, which would allow us to go ahead with a reorganisation of our operating model and consequent consultation with our staff. So we are sort of held in position at the moment. All of that said, we have done the restructure of our top team. You heard Paul introduce himself earlier on in a slightly new role, and that's to recognise and reflect our shift as an organisation to being focused on strategic commissioning. And you've just heard from Ralph, who is formerly our Chief Strategy Officer, and Henry, who remains our Chief Finance Officer, and I'll give you an update a little bit later on the finances. And many of you will have met Charlotte, our Chief Strategic Commissioning Officer, particularly at HOSCs. Marie Gabriel has been confirmed as the chair of the ICB going forwards. So that's a very quick update on organisational change. I wanted to, and Chair, if it's all right, I'll continue through the overview of the health updates and then take questions, unless you want to do it differently.
No, that's fine. Thank you. Yeah.
Great, thank you. So then we've given you a bit of an update on how the planning process is working this year. We've been asked through the summer to move quite rapidly to develop or to refresh our strategy. And you might recall our previous strategy was signed off by our integrated care partnership, of which councils, the voluntary sector, Health Watch and others are members. This is a refresh of the strategy specifically, it was specifically asked for in order to support our issuing of various commissioning intentions and plans. And so the slide in the pack sort of sets out broadly what everybody was asked to do. The ICB on the strategic planning, us issuing a set of commissioning plans, then trusts working within that overall population health strategy, but also working to the commissioning intentions that we'd set out to deliver 5-year integrated delivery plans. And at the same time, we are asked to develop 5-year commissioning plans looking forward. Obviously, that's been quite a lot of work over the last few weeks, but we have issued our pack of a draft strategy and our initial commissioning plans to providers and a wide range of partners across the system. You've got a slide in your pack which just sort of sets out what the commissioning plans or how we've grouped commissioning plans with a really important strand on neighbourhood commissioning framework. We're also expecting there to be some guidance coming out fairly soon on neighbourhood health plans, which we're expecting to need to be signed off by health and wellbeing boards locally to focus on population health need locally. I would anticipate them using the JSNA as the current health and wellbeing strategies do, but also looking to how neighbourhood health will develop place by place over the coming years. And we've also given you a slide, which is a sort of one-slide version of our system strategy. And this draws on work we did in the previous strategy, draws on a huge amount of public and user engagement and involvement, including through the big conversation that we ran and a whole series of other information and input we have from residents, and in particular puts both the good care framework that came out of some of that work with residents, but also the now outcomes and equity framework, which also came out of the outcomes that residents told us they wanted to see delivered in the centre of that strategy, and also starts to set out how we see ourselves delivering the 3 shifts set out in the 10-year plan. We've given you a little bit more detail on some of the other elements that are important to us, including our commitment to building and strengthening local partnerships. And then finally, we thought it might be helpful to talk about some of the things or set out some of the things that we have already done to embed the 3 shifts in the work that we do across North East London. So, Chair, hopefully that is a useful update. The thing, sorry, briefly, I forgot to say is as well as the ICB's changing, the regional structure of the NHSE is changing. NHSE will merge in due course into the Department of Health. Regions' functions are also changing. The model region document, which set out how the regions would work, was issued about a month ago, I think, and that sets out the regions as both doing the sort of regulatory function over providers and performance management of providers, but also setting the strategy for the region in which they work, so London for us. And then we're giving you a little bit of information about winter planning, because it's never too soon for us to start talking about winter. I'll stop there, Chair.
Thank you very much, Zena. Comments, Councillor Masters.
I've got 2 very different points. Firstly, I want to get onto the health inequalities point, just so we can release Paul. I think my point was there was a lot of talk in the papers about the strategies that had been devised, anti-racist strategies, people and culture strategies. I'm just wondering how this has been delivered and where the impacts are, given that we've now had ICBs in place for 3 years. And then my other comment is just generally, it would be good to get an idea of whether you've got a sense of where this is actually going, in terms of, I mean, what we're hearing is that the major issue with sort of bringing forward these economies is that they're unsustainable with the current structure. Are you getting a feeling, or has anyone indicated that there is a desire long term to move away from the ICB structure and head into another reorganisation? And where is place in all of this? Because when we were reluctant about, as local authorities, about moving to an ICB model, we were told 80% of the money will be spent at place. And as people who've come here tonight from different boroughs, we're aware of how much variation there is between the different boroughs, whether you're talking inner East London, outer East London. Is it that there will be a shift to the health and wellbeing boards being the representation of place and having to carry out that work? Or is it that they just want them sort of done away with altogether? Because that looking at your papers, that was my real area of concern. Where is place in all of this? So those are two quite meaty questions.
I wonder if we want to start with health inequalities, given that Paul's in the room.
So thank you, Councillor Masters. I think what we've done with health inequalities is focused on health inequalities and used the lens of health inequalities in everything we do over the past 3 years. I think our move into strategic commissioning and how we strategically commission going forward, we still intend to have those health inequalities lens on the whole time that we're actually commissioning. And certainly from a clinical perspective, I think that's going to be really important moving forward as well, because not only will we have commissioners, but we'll have clinical commissioners who will look at the quality and the patient safety aspects of commissioning. And I think that in itself will have more of the health inequalities within it. Within North East London, we know we've got a diverse population, and it's something we have to actually address as those health inequalities and how we can get better outcomes for all our local residents.
If I can ask a follow-up question though, have you got any examples of pilots or projects that have been delivered across North East London that have had a big impact on showing improvements in access to services or impact of those services on our populations? Because and anyone who knows me at a local level will know that I get really frustrated with strategies when what residents want to see is delivery and real change.
So I think we have got a number of projects, but I'm not going to write them off the top of my head, but a number of projects where we have looked at access and how we improve access, but looked within the different groups of residents we have and how that access has improved and where the differential is, so that we have to think about it's moving away from that health inequalities to health inequities. For some of our groups of residents, we have to do things completely different because they don't have the same access to those services that the others. If we just say the access is open and it's the same for everybody, it's not going to work for some of our populations. So we do work round about that and think much more about health inequities rather than health inequalities.
Can I add an example, Councillor Masters, if that's all right? And it's a Newham one, which is fortuitous, but it's only one example. So Newham Hospital have done a bunch of work using a whole set of data which showed that a particular cohort of women within the community, a particular ethnic cohort, were having worse outcomes from low birth weight babies. And that has led them into a very specific piece of work with that community, which is demonstrably improving outcomes for that particular group, right down to, you know, kind of the kind of the most harmful events that kind of happen at birth not happening, or happening with much reduced frequency. So there are examples all the way through our system of both what that overall really determined lens on health inequalities gives you, and how much progress you can make once you've got the data to show you what's really going on. Shall I move on to
second question? Sorry. Yes.
Yes. Shall I move on to the other question? So, and Councillor Masters, apologies if I don't cover all aspects of it. Do prompt me. Clearly, I'm not in charge of health policy and cannot predict the future. So bear all of that in mind. I don't think there is any intention to abolish ICBs. Certainly across the country, there is a huge amount of work going on in other places looking at clustering and merging ICBs. And I think were there a clear intention at the moment to just abolish ICBs, I don't think that would be happening. The thing that is stopping the move forward at the moment is that it is a set of issues around funding for the redundancies that are required, rather than any other policy intent. Just on place, and as you know, I think place is really important. As an ICB, we think place is really important. And of course, it is the place in which a huge amount of things happen. The very big focus for ICBs, and certainly for North East London ICB, is on really making neighbourhood working work. And that has to be done both at neighbourhood, but also within a place wrapper, because neighbourhoods exist in places. They don't exist in some arcane bit of NHS kind of organisational structure. They are real places where people live. As far as I understand it, the neighbourhood health plans, which form part of that operating plan panoply of stuff that I described earlier, will need to be signed off by health and wellbeing boards. And I think, whilst I don't think all functions which have been done through, you know, kind of health structures at place are going to be transferred into health and wellbeing boards, I do think there is a strong belief that health and wellbeing boards are a really important part of the governance of place, and should kind of lead some of that governance. And certainly we think that would be really helpful. We've been having conversations across North East London about how we are going to ensure, both with the ICB's reduction in size, that there continues to be a functioning, really effective partnership at place. Because, as I said, that's where kind of quite a lot of the driving of neighbourhood health and that sort of shift left and shift from hospital to community is going to happen. And we've been having a set of conversations in line with a London case for change on neighbourhoods about how we make sure that there is an organisation that can host some of those functions which support place development and neighbourhood development going forwards. So I hope that gives you a broad idea. You also talked about the sort of levelling up the kind of inequality of resources across some of our places. One of the pieces of work that we've been spending a lot of time on over the last year to 18 months has been working up and developing a set of core offers, particularly for community services, because we have needed to do that and understand what the core offer should be everywhere in order to really make progress with understanding why there is so much variation across place, making sure that every resident across North East London, regardless of whether they live in inner London, outer London, Newham, Hackney, has access to those core services. And then clearly there may be the need for some variation around those. So hopefully that kind of broadly answers your questions.
Councillor Hayhurst.
Thank you, Chair. First of all, Zena, can I thank you for your service over the last 3 and 4 years. We've been very lucky to have you. We all know you've faced immense financial challenges, but you've done so with sensitivity and compassion, while still clearly advocating for places. You have just done there, and we're sad to see you go. But I do understand from your note and your comment this wasn't what you signed up for, and so we very much respect that. But thank you very much for your service over the last 3-4 years. Can I just I was comforted to hear your analysis and your drive in terms of place, and I sort of share Councillor Masters' concerns. Like I can pretty much accept that the 80-20 principle is now out the window and isn't coming back. But really, you know, you would expect me to say this in terms of a Hackney position, but if I look at what we've achieved in terms of some of the lowest wait times at the Homerton, some of the lowest call on 111, some of the best outcomes on the GP survey, all of that has been led by clear leadership, people at place, an enhanced service, 10 million extra funding going into to that prevention at place via the GPs. And so I suppose the request I sort of made last night to Charlotte and to Chris is obviously on the board, and all of you on the executive is really to whatever you can in the framework that I understand you're going to have to move towards, because it is a blueprint, to do what you can to retain what you know works at our places and try and make that, and try as much as you can, as much as you're allowed to do, because as you indicated, there has to be a place wrapper. You can't just go straight from, say, 8 neighbourhoods in Hackney up to an ICB footprint, because in any event there will be duplication at the neighbourhood, but you need somebody holding it all together. So yeah, a strong desire for Ralph as well, listening to this, to move forward, to retain what we know is works. And if I've caught wind of this correctly, sort of Henry may be asking the each different department to sort of like save back, say, 1% to sort of move then towards prevention. I don't know whether I've got the right end of the stick there, but if that is the case, can we, you know, whether that necessarily stays within those organisations, or whether we make sure we do a levelling up on something like the enhanced services contract to really work towards the prevention, to actually really put the money where one of those main priorities are. But that's mainly comment to you all on the executive, to really a big plea from us. We've seen place work to that extent. We've seen devolution work to some extent, and not to lose that.
Yeah, thank you, Councillor Hayhurst, and thank you for your kind words. I really, really appreciate it. It's been a pleasure being in North East London. I shall miss it enormously. So all of that, you have been absolutely, and all members of the JOSCs, absolute, and local HOSCs champion place, and it is really important that we understand what's been achieved that way. And as you point out, the partnership work in City and Hackney and the kind of place focus is a big part of what's enabled the results that you've described. I'll leave Henry to pick up the finance questions later in his finance update, if that's all right. But I suppose I would just end by saying I think the opportunity that the ICB has as a strategic commissioner is to do some of exactly what you've said. So when the ICB no longer has quite the same direct responsibilities for trying to maintain everybody's financial sustainability and thinking about how do you shift resources, we have a kind of slightly purer focus, although obviously financial sustainability of providers continues to be important. We have a slightly purer focus on actually what does the data tell us, what does the insight tell us about where we need to invest in order to make the difference. And as you pointed out, things like enhanced services have been really successful in the past and continue to be in making sure that we do get the right outcomes and we keep people in the community and stop needs becoming acute.
Is there any other questions or comments on this item? Well, if there isn't, I'm not seeing anything, then if I can just add my thanks as well, Zena. You will be missed, but we wish you well in whatever comes next in your life. So, but thank you very much for your presentation today, and good luck for the future.
Thank you very much, Chair. I think we're going to, I know it's all part of one pack, but I think we're going to move on to Lorraine to give an update on what's going on mental health and community health services next.
Good evening. My name is Lorraine Sinduza. I'm the Chief Executive of East London Foundation Trust, and I'm the Senior Responsible Officer for Mental Health in North East London. So I will be representing ELFT and NELFT mainly. And then Paul Calaminas, the Chief Executive of NELFT, is the SRO for Community Health Services. I suppose just to overly say, I'm not going to go into the details of the slides, as I'm sure you would have read them all, but there's a couple of things that I would want to highlight. So firstly, we continue to work together, and particularly we created what we called improvement networks, and these are specifically designed for us to work as a system looking at clinical practice and also engagement with our service users and carers. All our improvement networks have service users and carers, and they look at particular things. So we've got talking therapies, we've got perinatal as well, and really thinking across the patch, where's the variation and what are the things that we could do differently. There's a couple of things we've been working on. So you would have seen something about assertive work in the community that has been directed following the tragic incident in Nottingham, looking at our own ways of working, but we're still waiting for some national standards and guidelines that will then speak to the way in which we continue to do our work. I think I will stop there and happy to take questions based on what is in the pack or anything else. Thank you.
Thank you, Lorraine. Is there any questions for Lorraine? Councillor Masters?
Hi, I wanted to pick up on the response to the mental health action points that we heard, I think, at our last meeting. I just felt that the response was incredibly poor. I mean, you're claiming that it's not a case of people dropping out of talking therapies, but that it's just a question of people being in the wrong service. Well, that begs the question about the quality of triage. There's a comment that in terms of sort of around targets being set nationally, well, surely that begs the question of whether they're the right targets in the first place. And then, you know, there's some talk about in terms of independent auditing that Scrutiny cover that. Now, Scrutiny, I mean, as someone who chairs a Scrutiny, I'm proud of the work my Scrutiny does, but sadly we have 4 meetings in a year and we're totally unable to cover anything. So I'd understand if talking therapies was a standing item on every Scrutiny across East London, but given that we can't achieve that, I don't really think you can sort of talk about Scrutiny sort of holding people to account. And we also know with regulators, you know, they turn up at a specific point maybe once every 5 years, or if there's real concerns sort of raised about a service. But again, it's not a kind of ongoing process in the way that, say, you know, within a local authority, you have a budget working party on an annual basis, sort of looking at what an authority is doing. So I just felt if I was mental health action, and I declared an interest at the beginning in the sense that I'm a member of the Socialist Health Association, but even if I wasn't, even if I was attending as a member of a different political party, I just think that response is really weak.
Okay, thank you. So before I start, just to highlight that I understand that these has been sent to many ICBs, and I think there's been interactions with NHS England. So I suppose for me, there's something about truly going back to what is talking therapies. And the issue in relation to the dropout rates is talking therapies is the most probably accessible way in which people who are experiencing anxiety and depression can get contact for support. Now, 90% of the people who come through talking therapies are self-referrals. And then within that, in terms of the triaging, you have a spectrum of people within that. So there is life incidents that will cause you anxiety and depression, or you feel anxious and you feel like you're depressed. There's the triaging process, and talking therapies helps people to either step down because they do not need specialist interventions, or get treatment, so low-level treatment, and there's a variety of treatments that people can get, or step up, and that's being referred to secondary for more specific interventions as well. So I'm not sure that I would agree in terms of the definition of what's being called dropout. Some people don't need intervention. Some people need low level for a specific time limited period, and some people will need additional support as well. I think nationally there's evidence that the majority of people who access talking therapy and get treatment actually recover, and then there's quite a high number of people who do improve as well. And if anything else is needed, then that will be provided or referred onward as well. So it's a process in that way, and it is supposed to work quite closely with primary care services. Some of the interventions, so not all interventions are specifically sort of individual sessions. It could be group sessions, but also psychoeducation, because sometimes how we are presenting is linked to something that's happening in our life. And sometimes some of that support, even if I think about some of our services in Elft, has been linking people with either job centres or ways in which they can help, because actually the cost of living is what's causing you anxiety. So it's not specifically that you have a long-term diagnosis of it. So real things that can support people. We've also noted, and I think one of the questions within there was about how, and I think you touched on it with Dr. Kaluli, is about how is it that we look at health inequalities. So there's a couple of examples in terms of what we've been doing. So in Tower Hamlets, for instance, working with the Bangladeshi community, and specifically, we've looked at interpreting services, because sometimes language is the biggest barrier, and where language can be a factor is in some of our languages there isn't a word for the things that people are expressing as well. And within that, it's working with people in their cultural and social context to think about how we can support them as well. There's a group in Newham where and all these things we're using sort of quality improvement methodology as well. So working with our service users and our clinicians to think about how can we work in a way that is culturally sensitive as well. And sometimes with some of our communities also talking about mental health and what it means, particularly within their own cultural context. And we've seen some improvement in terms of access, but also people remaining within the services as well. Thank you.
So Hayhurst.
Thanks, Lorraine. I think this is the first meeting we've had since the June Old Bailey finding of I'm wanting to say negligence, but I think it may have been more serious than that in terms of falsified records and quality of risk assessments. I think the trust's NELF, sorry, I'm talking about here, was acquitted of a more serious charge of corporate manslaughter. There has now been, I think, repeated instances from coroners and the courts in terms of the record keeping, as I understand it. Please tell me if I'm wrong, at both Elft and Nelft. And obviously that gives a significant lack of public trust. You, in your leadership role, what assurance can you give us that you're getting a grip of this in terms of leadership, spot checks, and this isn't continuing?
So thank you. So just to touch on the case at the Old Bailey. So regarding the charges against the trust related to the tragic death of a patient in Goodmayes in 2015, the jury ruled that the trust is not guilty of corporate manslaughter, but guilty of health and safety breach. The jury also ruled that a member of staff, a nurse, was found not guilty of gross negligent manslaughter, but guilty of health and safety breach. Following that, we're waiting for the sentencing for both the member of staff and NELFT, and that should happen in November. And there is some national work looking at the wider implications of this in particular. Yes, so there have been issues across the country in relation to the falsification of records. So speaking from an ELFT point of view, and before I took on this role, I was the chief nurse as well. We started a quality improvement project a couple of years ago just to think about what are the things that are contributing to this. Although an individual is responsible at that particular time to do the checks, there is something about us being absolutely clear that there are no systemic issues that are leading to people to work that way. There's a couple of things. Firstly, making sure that people who are on observation need to be on observation, but also understanding the workings of a ward and all the things that happen on the ward and the reasons why people may deviate from a specific process as well. There has been a lot of progress, and we've actually published something within sort of medical journals in relation to the work that we've been doing. We are clear there is individual responsibility in terms of your practice, but there's also responsibility wider for the entire team to make sure that what we're asking people to do is something that is possible, and also there are ways in which we can know how to make people safe as well.
Thanks, Lorraine. I mean, the Crown Prosecution Service clearly felt there was sufficient evidence to bring corporate charges. So I appreciate there was a acquittal in relation to that. But I mean, to some extent, I'm slightly concerned by your answer because it's very much focused on those individuals responsible, as opposed to, because there have been repeated passion, you know, as I understand it, on coroners now about the records, about absolutely making sure. I mean, are you going to be in a position to publish spot checks on a 6-monthly or yearly basis to say we're trying to really root this out at a corporate level, and we've put in place this system where we're testing ourselves? I mean, that sort of thing is the sort of thing that would give me assurance. But is that going on?
So if I just go back to what you've just said, I think I did note that it's not just individuals. I did say as individuals, as a practitioner, I'm a nurse, so I'm also accountable for what I do. But also that's why part of our review of the quality improvement is looking at what are other systemic issues that may be happening that may be leading for us to do that. We do checks, we do audits, and our teams have created ways in which we can also check, and making sure that people are adequately trained and also adequately supported. And if it is impossible to do observation, because sometimes people have missed observations because it is impossible for them to do, making sure that people feel safe enough to be able to raise concerns that actually I was dealing with something else was happening, there was an incident on the ward, I wasn't able to do it, and accurately documenting that, you know, you did your observation 15, 20, 30 minutes later because you were not doing something, as opposed to when something happens and then people want to retrospectively complete the obs as a way out of fear, actually, in terms of what's. So we have to look at individual cases, but we've got a program in relation to looking at what we're doing, and the work that we've done. We have seen a significant increase in the reliability of our staff completing OBS as well, in a timely manner, but when they can't, being open and honest in the moment about the inability to do so.
If there are no other comments or questions, then thank you, Lorraine, for your presentation. Oh, sorry, Councillor Stream. Sorry, beg your pardon.
Thank you. Slightly less exacting questions than have just been made, and it's to do with the response to the mental health action open letter, and on page 45 of the pack, there was a comment by the action group that longer term talking therapies are less available, and the answer was that that there was a stepped care model and interventions are time limited basically to fit the patient. But I just wonder whether you could give an example as to when a particular therapy might be longer term than is suggested. The other comment I'd like to make is about peer support workers, where there didn't seem to be statistical evidence as to the numbers that are being deployed. But I just think this is a very important, and I would like to know when that's available. And the other question is about the mental health support teams in schools, and saying that there's an intention to develop further 3 teams in January 2026 in City and Hackney, Havering and Waltham Forest. And I wonder whether the timing of that was still on track. Thanks.
Yes, I'll start with the easy one. The timing for the mental health in school teams is still on track, as stated. So that's the first thing. The second thing about peer support workers, part of the work we're doing with peer support workers is, so I can speak clearly enough, so I can guarantee you that all our directorates have peer support workers. However, one of the things where there was variation, it's where they were the banding, that's their level of seniority and the structure. We then decided that we need to professionalize the peer support workers. So they are now reporting to the chief nurse, like you would the nurses or the allied health professionals as well. And we're working with NALFT to make sure that we've got a consistent approach in relation to the training and also how we work out the numbers that are needed. And it's not just down to the teams, it's down to the organization as a whole. I had a chance to shadow some peer support workers within Newham in Elft, and looking at the work that they're doing, and they're absolutely amazing. So I absolutely agree with you. And then there's something about us being really clear about the pathways for them as well. So although we've got people with lived experience in all our different roles, this is specifically using your lived experience to enhance the care that we deliver. However, we also need to, I think, improve on the pathways for them to develop, either to remain as peer support workers and having a route for promotion within that speciality, or to be able to transition to other roles as well. We had an in-depth discussion at our mental health collaborative with NALFT, and so we're doing a piece of work so that we can have that level of consistency in terms of the job description, job roles, the training needs, the supervision, and as well thinking about how people progress. Your final question in terms of stepped activity, some people can go from 6 to 12 weeks intense treatment as well. What we mean by stepped intervention is you can have that, and then for talking therapies, but if people do need more and we think they need additional support, they can be referred to our sort of secondary care psychological services within our teams as well for more intense work that's there. So your initial triaging within talking therapy will determine what you need to have, but it doesn't close you off for having maybe longer term and being referred up. Or you can also be referred back to your GP for very low level continuing work with your GP as well. It all depends on the individual and the treatment that is prescribed by our practitioners.
Thanks very much. Thank you very much.
Jennifer, sorry.
Yeah. Thank you. Just in addition to the question around the step up, you're saying you can step down. What does that actually? What is that exactly? And the same with step up.
Step up, you'll be referred to a community mental health community mental health team and work directly with psychiatrists and psychologists and other people as well. So it's still in the same trust, but it's more intense. Step down is continuing to work low level with your GP As well as we know, GPs really work with people with varied conditions that don't need specialist input, and you can continue to be seen by the GP in that time. So it's not specifically within the talking therapist teams, but that's on an individual basis based on what clinicians feel you need at that time and what they offer within that service.
Right, thank you. If there's no other questions or comments, thank you, Lorraine, for your presentation. Thank you. So I think we're ready to move on to the next item, which is the finance review.
Sorry, Chair. I think we're going to move to Anne Hepworth from Barts first. That we're working through the pack. Is Anne there? Yeah. Thank you.
Okay, so that's fine.
Thank you, Henry. Thank you, Chair.
Apologies. I do apologise. Sorry.
No problem. So Anne Hepworth. I'm the Chief Strategy Officer at Barts Health. I'm really happy to answer any questions about the detail in the pack. But with your permission, Chair, I'd like to provide a bit of a broader overview in terms of where we're heading as an organisation, which fits with a number of the messages that Zena gave out earlier. So I just spend a few minutes on that, and I'll be referencing points that are in the pack as I do this. So we are operating in an increasingly complex environment. I think everybody gets that, everybody understands that, and we've been talking about that so far. At Barts hospitals, we are seeing more patients with more complex needs, and certainly the growth in demand is here and now. So we know about the population growth across North East London, but certainly we're already seeing increased demand. So, for example, in our ED department in August, Barts recorded the highest volume of ED attendance in England. So fairly significant there. And in terms of cancer referrals into Barts hospitals increased from around 4,000 a month to 5,000 a month. So the demands are increasing. And in terms of complexity as well, with maternity care, women that we're working with are coming with far more complex conditions, far more hypertension, diabetes, etc. So that makes maternal care far more complex. So we know that, we recognise that. So what we recognise is that we can't just keep doing more of the same. So we've really got to start changing how we deliver. And we've got an ambitious plan around that. And over the summer, we published our 5-year clinical strategy that you may have seen. And if you haven't, I would encourage you to have a look at that. And it talks about 3 key ambitions that we have in terms of delivery of our clinical services across Barts to respond to those complexities and that increase in demand. And the key headlines around that are that, firstly, we'll provide consistent care across our hospitals. So whichever place you live in, as you access our hospital services, you can be assured of consistent care in terms of the quality of that care and increased accessibility. And we'll do that by really maximising the assets that we have across all of our hospitals. The second ambition is around establishing centres of excellence. We already have some great centres of excellence in terms of cancer care, cardiology, etc., that patients from across North East London and beyond reach. But we're also looking to build on that in terms of excellent services around women's health, for example, excellent services around child health. And then the third one is to support integrating care across North East London. So 3 of our hospitals are established in 3 of the places, in 3 of the boroughs, and certainly have a good footprint and a good relationship with people in those boroughs. We would aim to continue that and to be a good partner at place with the other provider organisations and with people at place. And so that's kind of forming our ambitions. From a practical perspective, some of the milestones around that as we head towards those 5-year ambitions. Certainly this year, it's a challenging year. It's a challenging year in terms of performance. It's a challenging year in terms of finances. So we're working incredibly hard around our finances. Our aim is to have a balanced budget by the end of this year. That is no mean feat, and you will see some of the points in the slides around that. What we're doing as much as possible is protecting our clinical services from some of the changes that we're having to make, and really going hard on our corporate services to make sure that we are as productive and as lean as possible around some of that. We're also working really hard on faster access to care, and we're making really good strides in cancer waiting times, for example. We're making improvements in terms of our urgent emergency care and our ED departments. Diagnostics are steadily improving, but we know that there is more to do. So we will continue to push on that to deliver faster access to care. And then finally, less reliance on temporary staff is one of our key objectives for this year. We now only use agency staff by exception. We still use a fair amount of bank staff, but that's reducing. Our bank staff is our internal agency, and so that's often our own staff who belong to that. We need the flexibility of using some bank staff to respond to gaps, as I'm sure you understand, and a number of our staff like working on the bank as well, because it gives them flexibility, either flexibility in terms of times that they work, or flexibility to kind of work more in a lead up to major events, for example. So all of that work this year will provide us with a stronger foundation in terms of how we deliver for 3 to 5 years. So our ambitions in 3 years, and an improved outpatients department. Much of our work happens within our outpatients department, and many of our people who are on our waiting lists are waiting for a first outpatient appointment. So we're working hard to really modernise our outpatients department, because frankly it's the same as it was in 1948. And so we're really starting to look at how we make that more productive for a start. And you'll see in the use of text messaging to reduce DNAs, so that we're not wasting time in our outpatients department, is being really helpful. But also starting to use more digital messaging to make appointments, encouraging people to use the NHS app to change appointments if they are not suitable for them. All that with an eye on inclusion, recognising that for not everybody a digital service is the right service, but for the majority it is. So therefore we're pushing that in terms of productivity. And so in 5 years' time, so we're making a number of those changes so that in 5 years' time we can achieve those 3 ambitions of that consistent care across our hospitals, centres of excellence, and supporting integrated care. It means that we do need to work differently, and certainly we need to work differently across our hospitals and make sure that we are using all of the assets like the theatres, etc., to the most productive. But we also recognise that many of the improvements that we can make to healthcare do happen at place, and therefore our partnerships and our relationships with our primary care partners, voluntary sector, etc., at place is incredibly important, and we're putting far more effort into that.
Thank you, Anne. Is there any questions or comments for Anne? Councillor Lucas.
Yeah, thank you, Chair. That was a really helpful update. Thank you. You talked about innovation a lot in the update, which I think is really important. It's sort of frustrating to see that, the stats around missed appointments and 1 in 8 patients. Obviously, there's very good reasons for that for lots of patients, and particularly as you reference in the pack, the vulnerable ones. I wondered if you could just give us a bit of a better sense of how you talk about this campaign that you've launched quite recently, Your Care, Your Call, and sort of what the immediate feedback is about that. What are the KPIs? Obviously, it's fewer cancellations, but how does that work in practice? What are the inflection points, and how are you building innovation into that to make sure that it's easier for patients to reschedule or cancel or do it in a way that meets their needs? I'd be interested to hear a bit more about that.
Yes, we have just launched it, so it is a little early for the KPIs, but happy to come back with some of those at the next meeting. I mean, just simple things like text reminders have reduced our DNAs by 20%, and that's quite remarkable in terms of productivity. And we're using a digital system called Doctor Doctor, and that's where patients can really take control of how they change appointment times, and that's partly, we believe, some of the reduction in the DNAs, because it gives patients agency themselves over their treatment, and that in itself means that instead of saying, "Oh, I really can't make it, but I can't, I can't get through the hospital switchboard," or the letter telling me about my appointment has arrived in the post. For goodness sake, it's arrived in the post and it's only arrived a couple of days ago, and I can't change my work commitments to be able to do all of that. So those are the things. So it's at the moment it's quite simple things that we're doing, but they are making a major change. And even just using digital mail as an example will reduce our postage costs by £2 million a year, which we can use, better elsewhere.
Is there any other questions, Councillor Masters?
It's not so much a question, it's just congratulations on all the good work you've been doing around bladder cancer and improving careers. I've already checked in with Newham Hospital about the relevant things there, so we'll sort of take them up at ask, but thank you.
I'll pass that on to the teams, yeah.
Councillor Hayhurst, did you wish to comment?
Very quickly, in terms of levelling up in terms of the different hospitals in your estate, how are you proposing to do that with the different challenges that exist?
There's something about working more flexibly across those sites. So, for example, we have real specialists in ENT based at the Royal London Hospital and based at Whipps Cross Hospital, and that's great. And what we're doing is now working with them so that they're providing more flexible care across those two hospitals and being able to support those two hospitals. What that means is that we can also provide some of that expertise into Newham Hospital as well. So there's something about the rare expertise that we have, just making sure that it's available across all of our sites. And that means that as a group of hospitals, we do need to act more flexibly and work more flexibly. In terms of the history and the life cycle of the organisation, when we were first set up as an organisation, we were networked for the majority of our services across all of our hospitals. So that meant that if you worked in ENT, you worked across all of the hospitals. We were challenged in terms of quality of services, and many of you may remember us going into special measures way back in 2015, I think. And so as a result of that, in order to improve quality and get a better grip in terms of the services, we certainly became more disparate as hospitals with a group overview around it. That's great. Except what that means is we can't be as productive as we can be, and some of our expertise kind of gets lost and kind of trapped in one hospital. So now we're kind of moving back more to a middle ground so that we can get the best of both worlds, so that we do have excellent leadership in each of our hospitals to get a grip on quality, but at the same time we're able to share our really important assets in terms of the expertise across the hospitals. So consultant input, AHP input, maternity input, etc., so that we can learn and share and accelerate improvements across our hospitals.
If there's Councillor Sweden, sorry.
Thank you. I'm sorry for being last all the time. Thank you very much for your report. And I noticed on the section on further updates that talked about helping dozens of people in deprived and disadvantaged communities to get on the NHS career ladder. One of my many obsessions is to elevate the status of those who work in social care, having actually done that work in the past myself. And I just wondered to what extent you've been able to reach out to social care providers, both domiciliary and residential care, whose staff are generally from deprived communities and also have transferable skills, and access to the NHS would give a career structure from social care that doesn't actually exist, and hopefully enhance the status of people doing that work. So I wonder to what extent you've managed to create links with the major providers of social care. Obviously you can't provide, every provider, but to try and generate some kind of pathway for them to for their career progression?
To be honest, not as much as we could. So that's certainly an area that we have been discussing about how we do that, because I'll give you an example where we have done that. So through our life sciences team and the sponsorship of some of the developers around our life sciences ambitions, we've supported a healthcare college or element to Waltham Forest College, which trains up healthcare. Trains up students who want to get into either healthcare or social care. So there's some really good spaces in there for those students to learn. So there's kind of a setup of a home so that they can actually get some, practice, hands-on care. So we've supported that, but frankly, there's far more that we could do, and I think it's important that we do, because if I think about some of our challenges in terms of patients who are medically optimised who are in our beds, right? So patients who are medically optimised, they've come into hospital for acute care, they have received their acute care, they are ready to be discharged, and it's difficult to discharge. And that's often because we haven't got the social care placements for those patients. And so we're now starting to think quite creatively about how we can work with social care around that. Partly there is something there about the workforce in social care to be able to do that. You're correct in saying that we've probably got the better training structures, we've probably got the better clinical support structures in our organisation as a large bureaucratic organisation compared to very small social care providers. It would make sense for us to work with social care providers on training to be able to give social carers experience of hospital care and vice versa, so that we actually learn from each other. In doing that, we then get to understand each other's challenges, and we start to understand each other better, and therefore help to support those pathways. So that's why I'm kind of leaning into that space in order to improve the discharge pathways for patients who are medically optimised. In the same way, if we're supporting people who live locally and work in social care and are putting some growth and some social economic value back into our places, all the better. So that's a long answer to say we could do more. Yeah.
Right, if there's no other questions, I am mindful of the time. It's now 8:30, so we've got another half an hour, but still got a fair bit to get through. So, can we go on to finance, or is there other bits that we're missing?
I think we're straight on to finance, Chair.
Right. Okay. Thank you.
And I'm sure Henry will be brief, bearing in mind your time constraints.
Thank you very much, and welcome, Henry.
Thank you very much, Chair. Hello to the committee. My name's Henry Black. I'm the Chief Finance Officer, as Zena says. So I will be brief. The slides that you have in your pack, I'll take as read, and I'll just give the kind of the headline figures. As it says in your pack, the report relates to month 5, which is August, which was the latest set of accounts that had been approved by the various boards of the organisations in North East London. So that was the most up-to-date information at the time of the pack being put together. So North East London submitted a break-even plan at the beginning of the financial year to NHS England. That break-even plan required £368 million worth of savings to deliver a break-even position, which is an unprecedented level of savings beyond the level that has ever been delivered before. So always extraordinarily risky. In order to be able to hit that break-even plan, we were reliant on additional funding known as deficit support funding, which is additional funding available for NHS England for systems that have significant financial challenge. So we received that additional 43 million, which enabled us to submit a balanced plan, but that money was conditional on us hitting the plan at kind of regular quarterly intervals. So what you have, or what we have at month 5, is that we have a planned deficit of 29.4 million and an actual deficit of 59.5 million, so roughly 60 million deficit, which is off-plan variance by about 30 million. There are two main reasons for this. The first is that at quarter one, we were not hitting our plans, and so that we therefore lost the 43 million of deficit support funding that I explained before. So it's issued quarterly. So we have lost the first two quarters. We've lost the second quarter of the year. The first quarter was guaranteed, but the second quarter for months 4 and 5 has been lost. So that equates to about £10 million that we have lost out of the position. The other 20 odd million pounds is basically efficiency slippage. So where our cost improvement programs were expected to deliver the proportion of the 368 million. If you look on your second slide on page 20, I think it's page 26 of my pack. I think it might be a different page in the main pack, but it's the second finance slide that sets out the efficiencies, the cost improvement programs by organisation, and as you can see, at month 5 we were 22 million or 21.8 million behind on those efficiency plans. So clearly there remains a significant risk of delivery of the full year break-even plan. If we are not able to recover the position, we will continue not to receive the deficit support funding. It's already been confirmed that we have lost quarter 3's deficit support funding, so that is October to December. It is still being we are being given encouraging signs that if we are able to improve the trajectory, we may be able to earn back the deficit support funding, but at the moment nothing is confirmed. But as it stands, clearly that position means that there is a very significant risk that we will not hit our plan, and that will mean we will also then lose quarter 4 of deficit support. So we are being performance managed both against the headline number, but also where we have lost deficit support funding. That is acknowledged and recognised that it means that we will not be able to deliver the improved financial performance to overcome that. The main issue that causes us is that we will therefore lose the cash that comes with that additional allocation, and in particular North East London Foundation Trust and BHIUT in the outer patch are struggling significantly for working capital. So in other words, not having enough cash at times to pay bills. That means that they have to make an emergency application to NHS England to receive emergency cash in order to be able to do that. So it is a very, very difficult position across the piece. I'll stop there, Chair, and open it up for any questions.
Thank you very much, Henry. Councillor Hayhurst.
Thanks, Henry. I think that you've well explained the current situation, so I won't focus on that. Can you just explain a little bit more? Zena alluded to it. In the 10-year plan, what does the future position then possibly look like? The different acute trusts will be directly responsible to the Department of Health for their budgets, and the ICB is just responsible for commissioning and keeping a balance in terms of what it commissions. Is that the future? What the future looks like?
So the ICB will still be responsible for commissioning all services across the board, including acute services, and we will be responsible for ensuring that our populations receive the right level of care from the acute hospitals. What the hospitals will then be responsible for, once we've agreed a contract value with them, they're then responsible for their own operational performance. So in other words, if Barts Health receive 2.4 billion income, they will then have to manage within that. As it stands at the moment, the ICB has a role in performance managing where they can't keep their costs effectively. This is a rather crude way of describing it, but where costs are in excess of that income, the ICB has a role to play in performance managing. In the future, that role will be played purely by the regulator. So the ICB's role will be to commission those services, to agree a contract with a provider, and then the provider's own internal kind of processes to ensure that it can stay within that budget then is the responsibility of that organisation, and then accountable directly, as you say, to the Department of Health.
You use the word regulator there, but you essentially mean the Department of Health. But in one way, that's taking out a layer of, it's straight between the acute and the Department of Health with no one in the middle. So
it is in terms of a provider organisation being held to account for living within its means and staying within its budget. But it's the ICB will still be responsible for commissioning that provider and agreeing the value agreeing the range of services and the value of the contract to commission them.
Is there any other questions for Henry? I can't see anybody indicating. So thank you very much, Henry. And thank you for being brief.
Thank you, Chair. Thank you.
So moving now on to the next item, which is the item 10, improving GP access in North East London. Do we have a presentation on that? Thank you.
Thank you, Chair, and thank you for inviting us here today. Just to introduce myself, my name is Dr. Janican Crofton. I'm a GP in Waltham Forest, and I'm the ICB Primary Care Lead for Waltham Forest. And I'm just going to introduce my colleague, Sindhu.
Hi, Sindhu Krishnan. I'm the Chief Operating Officer who manages Addison Road Medical Practice on the 7 contracts.
I was just hoping if I could thread the whole thing together, and it looks like they've saved the best to last and the most topical subject. I think you can appreciate from the plan, as Zena mentioned, for residents in North East London, it's imperative that they get good access to primary care. And we know the health and well-being of our residents is much more improved if they get good, fair, fast and equitable access to primary care. So that's a given. I'm terribly passionate about access. In my other role as the North East London chair of the Royal College of GP, we're constantly lobbying health ministers and politicians around, if we want to improve access, we need to get more GPs on the front line, we need to improve premises, we need to look at recruitment and retention strategies, but that's beyond the scope of this meeting and this paper. What I really wanted to try and focus on is how can we bring general practice access into the 21st century? What does that look like? You can simplify that and say, look, you just improve the telephone lines, put more receptionists on and offer more GP appointments, but it's much more nuanced, technical and scientific. And we've been on a journey over the last 3 years within general practice in terms of improving our access models. And Cindy's just going to give you a kind of like a highlight summary of that journey in a particular practice over the last 2-3 years, bringing some of those realities to life. And then I'm happy to take some questions around what the ICB is doing across the North East London footprint in terms of improving access, and happy to take any questions around equity and equitable access.
Going to be very brief after you read the pack, and basically our journey started with a very difficult practice that was facing access problems in the community. It is the first medical center about 3 years ago. And what we did then is spoke to our residents and asked them what it is that they were actually looking for. So we formed a committee along with our PPG and looked at what their needs were, and then co-produced a solution, which is a 100% digitized access model where all our patients land at one dashboard through the ICB commissioned digital solution called Clinic, which gives us real-time data as to what access our residents need. We daily horizon scan the data and then look at what kind of workforce we need to manage our patients as they come in. We've had some great outputs because of the changes that we have made. And what I want to say is that we've actually carried our patients along with us. We've made sure that all of the solutions that we have created are co-produced with residents in mind. They've been an integral part of the solutions that we have created. Happy to take on questions.
Thank you. Thank you very much. Questions, comments? Councillor Masters.
Thank you. I mean, I'm just wondering, I mean, this is based in Waltham Forest. I'm just wondering, you know, if this is going to be rolled out, how you're going to deal with the unequal state of primary care across different boroughs, which are totally different levels of maturity. And then second question I had about this was where the new health hubs that have been laid out in the 10-year plan and now seem to be coming through quite quickly. There's been a lot of talk about it this week, where they will fit into primary care going forward.
That being said, I agree there is variation across the borough, and the ICB has got several strategies to try and address that. I think the ICB in its new strategic role has to take a more of an assurance role and be itself data-led. So we now have primary care dashboards that give us some insight into where practices may be struggling, looking at telephony data, looking at GP access data, that's an appointment data that's held nationally. We're then able to take a more proactive, preventative approach to practices that may have their own struggles with workforce recruitment, estate issues, and support where needed, whether that's through national quality improvement programs, local quality improvement offers, or more bespoke approach at a local place level, where people like myself, so there's 7 of me across the Nell footprint, someone like me would go out and do bespoke access visits with GP practices that are really struggling. That being said, we've recently got a program of webinars across the system where we can share best practice and have a little bit of a community of practice around how we can support one another. So a recent webinar, we had nearly 200 attendees on there. There's been a new contract change that's come out on the 1st of October, which now mandates that GP practices have to offer online accesses right the way from 8 to 6:30, which we welcome. It does have some challenges. We need to make sure that things are safe and equitable in that sense, but early evidence suggests that it's doable. I think what we need to look at going forwards is how we look at the outliers. The ICB is never keen to enforce contraction breach notices, but where that's necessary, where there are practices that, given support, given guidance, they are still struggling, we can take a more hardline approach. But the ICB will always take a non-punitive approach where possible, offering quality improvement support, but where necessary, we can take a more of a hardline measure.
Thank you. Councillor Hayhurst.
Thank you. I suppose a few observations. I think firstly, with respect to that new contractual change that all GPs have to have an online offer, you having an overview role, do you sort of have for those that don't already, do you essentially have a rough blueprint sketch to give to those GP practices that might be struggling or don't have it, to say, look, have you given them a pack to say this is what you need to do? There it is. Here are your 2 or 3 provider options. So have you got that there? A second aspect that I think is decreasing slightly from what we see in Hackney, but it's still a significant issue, is that cohort of the population that's still the wrong side of the digital divide as we move online. And I still haven't seen, certainly at a Hackney level or an ICB level, a clear blueprint from you to surgeries about what they do about that and what is the best practice for those that are on the wrong side of that digital divide and how you manage that. And I think if you can produce something, because I don't think it's there, I think I have been asking at Hackney level, and there's not a really well worked up strategy for that cohort. And then I think my third observation would be in terms of sort of, I've seen reference in this pack to sort of like maybe the digital hubs and things like that. What would be a terrible situation is if the direct contact with particular GP practices is replaced by a sort of localized 111 service, because I think we've all seen the problems with that when patients or residents don't get through to a clinician. They just give up, and so that would be a disaster if somehow it was deemed to be more efficient to have a sort of like a local telephone hub, that inevitably when cost saving has come, there's not a qualified GP at the other end of the phone. It just becomes counterproductive, and so to sort of try and work around that.
Yeah, I'm happy to take that. Cindy, please do come in. So modern general practice access, many practices have been doing that for some years, and for those practices, they can shift to this new online requirement quite quickly, and we've seen them adopt quite quickly. some more traditional practices that have never implemented and have been quite traditional in their approach, they need a more of a bespoke approach. Equally, they need to look at their local patient demographic and see whether that digital total triage model suits their patients. So there is a national drive to modernize general practice, but it has to meet the needs of the local patients, and individual GP practices need to make a judgment call on that. Now, what offer is there? So there is national GP improvement program offer, quality improvement, but coaches can come in with a playbook, with a blueprint, fly in and offer like a 20-week implementation program. That works for some practices. Locally in North East London, we have Equip, which is our local QI partner that can come in and provide some QI support. But there isn't a sort of manual, this is how you do it, necessarily out there. It has to be tailored locally. With regard to digital exclusion, the NHSE, again, there's lots of digital exclusion protocols, measures that you can put in place. We do, at each place will probably have some within their council, digital champions that can help support. But again, each practice has to have its own approach to digital exclusion and how they support those that are potentially missing out on these new approaches. Does the ICB have a blueprint to just roll out across all the practices in North East London? I'll have to take it away. I think that could be an aspiration that we could aim for. We do have digital inclusion champions that are working with the ICB, but something that they could lift, to shift and deploy quite quickly, I think could be something that the ICB could take away. Centralized hubs, again, this is a solution for this particular practice and organization that, again, is not the solution for every practices. We don't want to be in a position we're having an impersonal one-on-one service which sits above practices, which sometimes can be formulaic, algorithm-led, not GP-led. We know that GP triage works well when you put your most efficient, most skilled, most knowledgeable clinician at the front door. It works on the battlefield, it works in A&E, and it works in general practice. If we take that away from GP practice and devolve those two, I think we're losing a bit of a trick there. But yeah, Cindy, come in if you want to say anything there.
So it's very important for all of the triage hubs to be very GP-led, and it is the clinician who decides what is the best care for that particular patient who's come in. And when you have the entire access on a dashboard in front of a clinician, and when they decide what the best way moving forward would be, either signposting the patients or making sure there is another AHP who's a paramedic who goes out and sees the patient, there is an efficiency case there to be, shared with the rest of all of the practice. But of course, it is based on the demographics of each of the boroughs that we serve.
And I forgot to pick up the neighbourhood health centre question. I think where there is a vision for different places to set up neighbourhood health centres, I think there is always a vision to incorporate primary care into those places, whether that's on the high street, in shopping centres, incorporating diagnostics and primary care. We know that it works well. So it has to be assessed on a case-by-case assessment, but we know a lot of the estate within general practice across North East London is not fit for purpose. So where there is an opportunity to build neighbourhood health centres, as an ICB, we'll be keen to incorporate primary care into those spaces.
Thank you. Is there any other questions? Councillor Keating.
Thank you very much. Is this possibly a way of positively keeping original infrastructure when a mass development goes up? So let's say a mass development of housing goes up and you need to up productivity in the current medical centre that's there. Could this be a way that we could do that?
Yeah, I think whenever housing developments are built, I'm not an expert, but there will be an impact assessment made on what the health requirements will be. Is your question, should we be then using that as an opportunity to try and assess the capacity and capability of existing GP practices?
Right.
Yeah. Yes, I mean, if we're strategic and we're joined up and we're working as a health and care system, we should be having those conversations, and then they should be proactive. I think we could probably do more in that space. Do they happen? I think they probably would happen in I'm not sure exactly what settings, whether that's happening in health and scrutiny or in housing, but certainly when there's new health centres being built in new premises, when you're when you're being awarded a contract to a new practice, a new provider, there is a rigorous assessment that goes on to make sure that that provider has robust access models.
And just to follow up on that, and this may be for partners here with the hospitals, and that's on these redevelopments and current infrastructure around medical clinics. I've been getting a lot of reports around like the Thames View and Barking Riverside area that they only have one clinic, and I'm wondering if these mass developments that are being built, if they are a worry for our current A&Es, because our GP services are currently overwhelmed.
I think I'm quite involved in that housing development and the provision of services in there.
Did you want me to come on?
Yeah, go for it, Zena, go for it. Or if anybody else wants to come in, please do.
Over to you, Zena.
Thank you very much, Councillor. So, yeah, thank you. Dr. Crofton is an amazing primary care practitioner with amazing knowledge, but I'll just step in on the kind of wider planning. So when there is major development planned, particularly at scale, we always aim to work closely with local councillors and councils to understand what health provision is needed. We have a set of kind of fairly standard requirements that get plugged in. We also have local estate infrastructure forums, which bring together the council and us and health providers to really think through what is the additional provision that is required. That kind of sounds very straightforward, but actually it's a really complex process. And Councillor, you referred to Barking Riverside, where this has been, kind of a really quite difficult venture for various different reasons. And as you say, a growing population also impacts significantly on other health services, not just hospitals, but mental health services, community health services, as well as primary care. And one of the arguments we've been making as North East London for the whole time I've been here is that we don't feel that the way that the funding formula works adequately takes account of the rapidity of that growth in North East London, because, well, for various complicated reasons that I'm very happy to talk to you about, but you probably don't want me to at this particular point in the evening. But just kind of please do be assured that we do work with all of our partners to plan as much as we're able to within that context for all services for a growing population.
Thank you, Zena. I am mindful of the time. We've come to the 9 o'clock kind of deadline. I don't particularly want to close the discussion down, but unless there's anybody's got anything further to add, then it just remains me to say thank you very much for coming along tonight, and thank you for presenting. And I think we've got one last item, but I know the officer is going to be extremely brief on this one.
Yes, I'll try to be very brief on this one. This is the scrutiny report at item 11, and I just wanted to draw members' attention if you have any suggestions or comments on the forward plan, the action tracker, or the recommendations tracker. I also thought I'd highlight the next meeting date is 14th of January. Members should be aware of that and should have a calendar invitation, but I can issue that if not.
Well, that does conclude the meeting, and can I thank all the presenters for coming along tonight and with their presentations, and those within the room and those online. And just again, Zena, we wish you well, and thank you, members, for your attending, and thank you for those that have observed either online or in the room. So thank you very much. Thank you. Thank you.
Thank you, Chair.